Welcome to today's webinar. The topic for today is understanding benefits of external cueing. And my name is Kelly Sullivan, and I'll be hosting the presentation today. As a reminder, this webinar is intended to provide general information, not legal advice. We have two great experts joining us today, and I'm honored to introduce them. Maria Allen has been a physical therapist for the past 40 years, working on a wide variety of settings, but primarily focused on neurological rehab. After almost 20 years working in brain injury rehab, she began focusing on working with Parkinson's disease in 2011. She now runs a Parkinson specific home health program on the central coast of California and teaches Parkinson specific power moves therapist workshops for physical and occupational therapists. Jennifer Bazan-Wigle has worked in neurological rehabilitation for the entirety of her physical therapy career. She is currently a physical therapist at Parkinson Wellness Recovery's Power Gym in Tucson, Arizona, where she specializes in one-on-one rehabilitation and group exercise instruction with people with Parkinson's disease. Jennifer is a senior member of the Power Moves professional education faculty and has delivered over 100 training workshops across the US and world, training physical therapists, occupational therapists, and fitness professionals to implement evidence-informed rehabilitation and group exercise for people with PD. She has earned an advanced credentialing from the American Physical Therapy Association Geriatric Section as a certified exercise expert for the aging adult and as a credentialed balance and falls prevention professional. Maria and Jen, I'll turn it over to you now.
Good morning. We're very happy to be here this morning. And I'm going to start us off this morning. So I know we should have some physical and occupational therapists. I'm not sure if we have any speech therapists, maybe some nurses watching us today, as well as some administrators. So hopefully you'll all understand external cueing and feedback mechanisms, recognizing when you need to use some feedback and cueing, how to use those cues and decide which cues and what's most appropriate for a cueing mechanism. We're going to talk a little bit about the research that talks about driving neuroplasticity and motor learning for a variety of different clients. We have a lot of videos for you today. So we have videos and pictures with a variety of clients. So we hope to give you some really good options that you can easily apply today, tomorrow with your patients when you see them in the clinic, or as I do, see them in their home or in the assisted living facility or wherever you get to work with your clients. So let's start off. I'm going to start off talking a little bit about motor learning and what motor learning is. Motor learning is a set of processes associated with the practice or experience leading to permanent changes in the capability for movement. So we're talking about therapy as us being teachers, as therapists, teaching movement, leading to improvement in functional mobility. Motor learning involves learning a skilled task and then practicing with a goal in mind. So again, when we talk about therapy and what are we doing that is skilled, what is the skilled part of our therapy? We're teaching skilled tasks, and we are working towards a goal. A patient-specific goal is where we should be working in therapy. So the goal really is to have this task be executed automatically, or automaticity of this task performance. So how do we get there? What we learned in school, and it's interesting, I went to school in, way back in the dark ages, and anything before 1990, we really didn't learn a lot about motor learning, because the 90s was the decade of the brain where a lot of this research started to really develop and build. So it's great to have this understanding of this background as we move forward into understanding how the brain works. When we think about the term feedback, in sports, we're looking at improving in performance for an athlete. So there's a lot of research in sports and athletics about feedback and the use of feedback. In rehab or therapy, we're actually helping patients regain motor functions because of a problem with an injury, a disease, something going on there. When we provide feedback, we can provide feedback that's about the intrinsic or sensory information that's about what's happening inside or within the body, or we can provide augmented or extrinsic feedback that's provided outside the body. And when we provide that feedback outside of the body, we have a couple of different types of feedback, either knowledge of results, so which gives them the information about the desired outcome. So success, failure. Think of a basketball player shooting a hoop. If they make the basket, that's success. If they don't, that's failure. Or knowledge of performance, which informs the learner about how they're moving, the characteristics and the quality. So manipulating these different types of feedback during these motor tasks is important, and that's what makes a good coach or a skilled therapist, and how we manipulate the feedback that we provide. When we think about manipulating this feedback or cueing, these sensory manipulations, it's changes into that sensory environment to change the behavior or the performance of the task. So we can add things to the environment, we can take things away from the environment, or we can change things. So adding things like a cue, something to touch or hit, removing things could be removing vision, removing distractions, altering the surface would be alteration. So lots of different ways to manipulate sensory information. We can also use that manipulation before the activity or the task to cue or prime to get ready for those upcoming movements. And we know that if we use highly task relevant sensory information results in more context dependent learning. So we know that, but we also want it to generalize. So how do we get it to generalize in both rehab and in therapy, as well as in athletes? So thinking about how we manipulate this and get this to be more applicable to real life, we think of feedback, which is basically information that's fed back or fed forward. We can do feed forward cueing, where we're just giving them information before, during, or after the task. And that can be extrinsic, something outside the body, or intrinsic, something inside the body. Cueing is the tool we use to provide this feedback. And when we provide that cueing, we can either provide it with an internal focus, which is something that is very common. And I think I learned in my early days as a therapist, we use that kind of top-down approach, that the more input we put in, the more output we got out, using a lot of anatomical cues. So that internal focus is one way to provide a cue, and then external focus, providing visual, auditory, or somatosensory cues, or a combination, a multimodal or combination of those is using those external focus cues. So we know that giving this feedback or figuring out which feedback, how and when to provide it is both an art and a science. At the end of the day, what we want is competency, consistency, and independence in this functional activity as a therapist. So that end stage goal is automaticity. So how do we get to that stage of automaticity? I'm going to let Jen talk to you about the different types of cueing and how they work in our population.
All right. So now we're going to talk a little bit about that external cueing component and the different ways that we can cue people and what the research is telling us of why we should be doing it. So let's start with visual cueing when we think about external cueing. Vision, of course, is essential for producing all of our purposeful movements. It's our predictive sense, right? It's really deep seated in brain function. It takes up a lot of space in the brain. So visual cues can be highly relied upon for a lot of our clients and our patients, especially when we're just starting to learn a new task or that motor learning is just beginning. Okay. Visual cues like dots, like a scarf, like something to hit or something to draw your visual attention to. And that's going to be really important when we're wanting to improve the success, especially of a task that's new or novel to someone in therapy. Always good to know that as your motor learning increases over time, we're going to use less of our vision, so that decreased need for this explicit use of those visual cues. However, I always like to preface that we put all these visual cues out there, and it's important as therapists that we slowly begin to remove those visual cues to see if motor learning is happening, if generalization is occurring. Know that you'll see a little bit of decrease in performance as you do that, but knowing when and how to pull those back is really necessary. There's also always a caveat to taking away all visual cues. I always think that, as Maria was saying, our goal is automaticity in general for a task. But if that is not the goal, because the goal is really safety, and those visual cues offer that kind of safety, then we're going to maintain that. We're going to keep those visual cues there to help someone be safe in that environment if needed. All right, so just quickly thinking about the summary of visual cueing, we have visual information is going to help, especially when learning a new task. And then, of course, over-reliance on visual information can create some dependency. So as therapists, it's really up to us to try and pull back just a little bit so that we can actually see that learning is occurring. There's lots of research in stroke, Parkinson's disease. Of course, we talked a lot about athletes, and that's kind of where a lot of the research is emerging, and also in speech therapy as well. We're going to look at just a few examples here, and these are actually just photos. So thinking about the first gentleman, you can see that cards are being placed on the treadmill belt as he is walking, placed right in front of his foot as a visual cue to help him be able to take a bigger step due to some of his issues with walking. You can see the second picture, someone has a laser. So now you have using your vision, using that laser to target where you want to look and where you want to go. The third picture, using numbers, letters, colors in different planes of view to help someone's balance and stepping response. Okay, now we get to wonderful auditory cueing. And with auditory feedback, it can play a huge major role in our rehab, because our go-to is vision. All right, that's kind of hence the last part of the research. We tend to want to go to and utilize our vision, but vision can sometimes, especially in recovery, depending upon what's happening, can be overburdened. So let's utilize this auditory cueing as kind of a fresh perspective for the learner. In terms of feedback, it's going to improve overall learning by reducing actually some of the workload. There's a strong connectivity between the auditory and the motor regions, which can kind of explain the natural tendency to integrate auditory information and movement. I think the best example I can think of is dancing. You've seen probably many videos of people having a really challenging time moving or walking, and then all of a sudden they hear a song, which really triggers those areas of the brain, the basal ganglia, which works on habitual movement, automatic movement, and it also connects to our cerebellum, so working on timing and coordination and planning. And all of a sudden, all this beautiful movement fluidity actually happens when they hear that auditory cue, which is really quite wonderful. We should really take advantage of that. So let's just look at the summary of auditory cueing. It is readily integrated into movement. And again, using that cueing of auditory, we should be using it in rehab, especially when we're wanting to improve rhythmic movement. And walking is a perfect example. It's supported. There's lots of music therapy, neurologic music therapy. When we look at the research with music in the brain, we see that even dopamine is actually released when we hear a song that we absolutely love, which is great. We can again use that to our advantage as well. So let's look at a couple of examples. One is just a picture. You can see Maria there. She is doing some dancing. So again, utilizing music as a way to drive coordination, drive timing of her movement. And you can see how expressive she is even while she's doing it. A lot of automaticity happening there after a lot of practice. And then we also have a video of someone who is there, yeah, has some freezing of gait, but utilizing metronome as a way to help improve symmetry and maintain fluid walking versus an acceleration of walking. All right, let's move on to somatosensory cueing. And a lot of us, I think there's a lot of synonymous terms for somatosensory: proprioception, kinesthesia. Those are very synonymous words. So we're going to stick with somatosensory cueing. And looking at the research on this may be the motor planning magic bullet that we've all been waiting for, that we should all be using. It is a critical component to motor planning. And the somatosensory and the motor centers are located right next to each other. So they're really tightly coupled. And we want to exploit this to improve motor learning. All right, we want to help people to feel where they are in space better, and that's what that somatosensory cueing is going to do. This type of cueing may be more robust than even the visual or the auditory cues, and how that affects our rehabilitation. So we want to make sure that we're driving that to get new motor skills. Thinking about that, just the summary of that. Again, we're looking at how robustly the somatosensory system can be, even a little bit more, may possibly be more than visual and auditory when it comes to planning and learning. It is going to improve skill acquisition. That's that automaticity, that generalization that we're trying to go for. Lots of studies, especially in Parkinson's, because we see that one of the main areas of symptoms of Parkinson's is decreased kinesthesia, decreased proprioception. So that's where we see a lot of the studies for that. The studies looking at the SAFE study by Sage and Alameda, where we have two sets of exercises, one done with eyes open, and the second time done exactly the same except with eyes closed, and how we can see improvements in motor symptoms, improvements in even functional mobility, because the tasks are being done with movement over ground. Thinking about how we can affect overall movement, especially when we're moving and thinking about agility, so dynamic balance, while you're wearing dark sunglasses. So you're changing the perception, the visual perception, taking some of that vision away. Using what we call dribble glasses, basketball dribble glasses, and they're kind of cutting what our vision is being able to see. And of course, varying the surfaces, so changing what we're actually either sitting on, standing on, and changing that to really really think about how we're affecting that somatosensory system. Lots of different programs, exercise programs out there that also increase attention and that proprioceptive awareness, like Tai Chi, yoga, both have very high amounts of research improving balance and gait. Qigong, Feldenkrais. Feldenkrais uses a lot of metaphors and also motor imagery, which can be very powerful as well. If we look at a neurodevelopmental treatment, thinking about how that can also be a type of somatosensory cueing as well. Let's look at a couple of examples. And again, these are just photos. The first one being someone that has that TheraBand, and we've attached them to the ankles. And that being that somatosensory sensation. So he's not looking down at his ankles, but he has this feeling that someone is pulling him back, that hopefully, again, at that ankle will help to drive that larger step length. Also resistance, the middle picture, looking at resistance at the hips and at the trunk, trying to drive more extension with movement and walking. And then the last picture, you can see one of my colleagues wearing the basketball dribble goggles to cut the bottom half of the periphery to force vision looking up and ahead to the horizon. And last but not least, and this wasn't on our awesome little graph that we showed you guys, but thinking about the research in multimodal feedback, and wow, can we always do this, and try and see how we can manipulate those cues, not just one type of a cue, but maybe a combination of them. So when we use a combination of those feedback cues, we're going to increase the processing of information. It can improve learning, which is, again, what we're always wanting, versus just a single feedback. So I always think I want the most bang for my buck during my therapy sessions with my clients. And so sometimes trying a couple at the same time can be really powerful. The brain may process these feedback cues faster and can also maybe hopefully lead to more retention. Yay, retention. And the research suggests that we as therapists, we can develop these really effective interventions when we identify and manipulate that feedback that's most relevant even to the task at hand. So let's look at a few examples here. Nice, David. Nice. And so there in this video, we can see David is using visual cueing, audio cueing, and it's actually a little bit unpredictable. So he's actually also doing a little bit of cognitive training as well. So that's kind of a way that you can see how we are combining that type of feedback, visual in multiple ways, not only with the dots on the floor, using the agility poles with the different colored scarves on top. So his visual cueing, his tracking is going, but he's also listening to the cue on what color he needs to go to. The second picture is just a picture, but that again is David. And in his hands, he's got these green rings, and we call those smovies. And those smovies give feedback in both somatosensory and audio. There are 4 large metal ball bearings inside those rings. And as he swings them, and the more vigorously that he swings them, he's not only going to feel them in his hands through the limb of the arm, but also he'll be able to hear. If there is no sound, that lets him know he's actually not being very vigorous. He's not swinging his arms quick enough and fast enough and big enough. So now that takes us right into the optimal theory. I'm going to move that over to Maria so she can give you guys some of this great information on this wonderful theory that we use every day.
So the optimal theory is from researchers Gabriel Wolf and Rebecca Lewith, and it came out and was published in 2016. It's optimizing performance through intrinsic motivation and attention for learning. So things to think about when we're trying to optimize learning. We want to have conditions that enhance expectations for future performance. So they really want to have knowledge of results. They need to be they're working towards a goal. They want to it's this motivational part. But one of the big components of the optimal theory is using this external focus of intention instead of that internal focus to get the intended movement effect. So there's lots of research on external focus. The optimal theory is kind of where we go to think about, how can we make get our patients motivated, give them the buy-in to really work towards those goals. So some of the really interesting research on external focus of attention. Yeah, there's a research in Parkinson's with treadmill training where they looked at just treadmill training and increasing the intensity, so speed, making them go faster over a fairly intensive bout of treadmill work, and they didn't improve. So there was no improvement in this treadmill study, even though they worked really hard. They got worse, essentially, on some of their functional tasks. Whereas when they did treadmill training with a little bit of external cueing, motivation, coaching from outside, as well as a little bit of therapy, people got better. They showed improvements in all their functional testing. In weightlifting, when they used internal cueing, again, they were worse than the controls. So they actually decided that no cueing is better than internal cueing for that weightlifting task. And in athletes, there's just a lot of information that shows that external cueing improves learning speed, skill retention, and in the end, it really improves those goal-oriented tasks, especially strength-based tasks that require a lot of skill. So we know that internal focus, it inhibits some of that automatic processing. It creates some overthinking. People, pay too much attention to the details, and they're not able to generate that good quality movement and have that become more automatic. We know that external focus is going to facilitate that automaticity, or that subconscious performance of the tasks. So let's try a few examples of external focused verbal cueing. And as a therapist, I know a lot of times we talk a lot to our clients. Sometimes we need to talk a little less. Sometimes we need to think about the words that we're using. So for example, let's take the direction or the cue of walk, heel, toe, right? Let's walk, heel, toe. Let's get that heel out. Let's get that heel toe walk. Instead, why don't we try saying something that's externally focused, like leave your footprint. So leave your footprint. That makes people more intentional, tends to get people to walk with that whole body, whole foot roll from their heel to their toe. I like walk like a speed walker, which is kind of a metaphor to get someone to really get those heels out and walk quickly. Nose over toes. Let's try saying things like reach for the wall to get that forward momentum, or reach for a target out in front. Or maybe just tell somebody, jump out of your chair and go get something. That helps with that idea. We often tell people to lift your chest. Maybe show me the logo on your shirt. What does that do if I say, show me the logo on your shirt? I had a lady yesterday that had flowers on her shirt. So it was like, show me those flowers. And automatically you get with that focus of that task. So that external cue is a task for them to do. Straighten up. How about stand at attention, especially if they've got a history of being in the military? Or try to get your head to reach up to the ceiling or touch the ceiling. We're often trying to get people to depress their shoulder blades, and maybe it's the cue of put your shoulders in your back pocket. That's an external cue of something to do. Or squeeze an orange in your armpits. Automatically gets that shoulder blade depression and a really good posture. Open your hand, right? Open your hand. That's maybe a flick water. Just flick water. So for me, I automatically just move with good amplitude and get really nice open hand. Lift your arms. What would you say? Think about what you might say instead of lift your arms. How about reach for the sky? Again, you can come up with all different ways to do that. Oftentimes we're trying to get someone to sit down. It's like bend over, bend your hips. Sometimes we'll use the word hip hinge. Those are all kind of internal anatomical cues. How about bumping the door shut with your bottom, or bump your bottom into the back of the chair? And a lot of times when people are standing or walking, they've got a little supination and external rotation and hip retraction. Let's try something like screw your foot into the floor. So now I've given them a kind of an external cue of a task to do. So those are some good ideas for you. And then I think Jen's going to talk a little bit about some of our ways we optimize quality when we're working with our Parkinson's patients that will work with all of your clients.
Yeah, so we love that idea of thinking about cues being both instructional. That's again what we're all saying. Those are those wonderful verbal cues that we're giving our clients. And then, of course, informational. So let's think about instructional first, and that's a lot of what Maria was just talking about. Again, trying to utilize motor imagery, thinking about how something that someone has already done many, many times in their life, they can actually sit, close their eyes, and imagine themselves doing it. Even using a video of some kind can be extremely powerful to really be able to perform a task better. Metaphors work great. So a lot of those, that list that Maria just gave you has a lot of metaphors. So thinking about how we can utilize those and even making those metaphor connections as we get to know our clients. We want to make sure that we use simple language. We want to make sure we have people plan and rehearse movements. They can always do it a little slowly. That's our time to instruct and use the environment to help them move better. Allow our clients to self-reflect. Ask them, how does that feel this time? How did that was your best repetition? What did that feel like to you? Again, using those external focuses of attention, using the environment around us to help. Again, like reaching for the sky, pushing your hips back to the wall behind you. I love analyzing and having my clients problem solve. And again, using video feedback can be really powerful to get that to happen. Informational cues, these are the things that you guys have been seeing a lot of those from the videos and the pictures, thinking about your visual, your audio cues, even using some of those somatosensory. So external cues are the targets that we're using, visual and or audio. Your internal sensory feedback, again, that's that kinesthesia and somatosensory. So thinking about feeling what the floor feels like, the wall, even if you're using walking poles or a walker, using that as sensory feedback to help you with your movement. And thinking about how even equipment can be multi-purpose. It can be both an external cue, it can be an internal sensory feedback. I always think about walking poles because they can be a cue. I can actually set that out in front of me as an external cue to get me walking. But it can also, I can feel it in my hands. It can give me information even about my posture as I'm pushing down into the ground. So as we move to just looking at some simple equipment, it can go from very low-tech equipment to very high-tech equipment. Maria's got some great pictures. This is actually the first picture is her little care package that she gives to all of her therapists that work with people with Parkinson's. So you see low cones, dots, little bean bags, scarves are like the most fabulous visual cue, and even tactile cue. Boom whackers, audio, proprioceptive, and visual cueing. Thinking even about app examples. So metronomes are free. So please, everybody put them on your phone immediately. Clock yourself. That was actually what you were listening to with David. And that was just a simple colors little section of Clock Yourself created by another physiotherapist. Some high-tech examples. Blaze pods are wonderful as a visual cue, especially when working on visual cueing with cognition. Next stride, of course, that's utilizing both visual and audio for improvements in walking. Headlamps are really inexpensive these days, which is great. So using headlamps and lasers for visual cueing, and of course, it's kind of endless.
And in my little box there, you'll see some little colored dots, some post-it notes are great for all kinds of things. There's TheraBand in there for providing some of that feedback, giving some feedback for different activities. There's painter's tape and other colored tape. So again, there's simple all the way up to some of the fancier texts and apps.
Yeah. And last but not least, we'll just talk a little bit about Parkinson's disease specific considerations, especially when it comes to gait training for Parkinson's. I'm going to encourage all of you that are seeing people with Parkinson's to please use feedback and really thinking about how you can even change and personalize that feedback, because guess what? People with Parkinson's respond to different kinds of feedback, also depending upon their disease severity, where they're at, and what their symptoms are. Gait training, of course, it requires a lot of time and a lot of practice. The good part is that we're walking a lot, so we want to provide the best kind of feedback and cues to optimize gait patterns and try and get that gait pattern to be the best it can be, right? We're trying to work towards getting closer to using those strategies. I kind of think of them as like detours to help people improve that quality so that that neuroplasticity is really good neuroplasticity. We don't want negative, we don't want people to practice poorly. We want great practice to get the best walking. And it is critical in gait rehab for people with Parkinson's, because the closer feedback to the time of the action, the better it's going to facilitate learning. So please use all the types of cueing for your patients with Parkinson's.
We know there's lots of good research. We've talked about the fact that external cueing is where we want to really focus. When we use that external cueing, we don't fuss over the details, we get more automaticity, and we're more efficient. We don't tense up as much, we don't use as much, kind of frees up those cognitive processing resources. It's an attentional focus on the wrong thing when we're focusing in their body. We want that attentional focus on the goal, on completing the tasks. So we can do more with less. We use less muscle activation because we're more relaxed, we're more efficient, we're more fluid. When we think too hard, we tense up. So we want to think about, and Dr. Farley, who Jen and I both work with, says we should train our patients like athletes. We need to do that. And Mike Studer, who's a big researcher and in Parkinson's and other neuro, says we should use the term geriathletes with our older population. So here's the fun part. Now we're going to get to some disease-specific cueing considerations and videos to show you some ideas with different populations. And the goal here is to start with a little video. I want you to watch this person, just watch them walk. We're focusing on gait activities, and think in your mind, what do you see? What problems do you see? What would you want to work on? What do we need to do to make this better? So let's watch and see what we see. So I see a lot of things there, and I'm sure you picked up a lot of things there. Obviously, there's a lack of knee flexion pre-swing and through swing phase, the stance phase on that left leg. So this is a left total knee replacement after total knee replacement in a healthy middle-aged woman, and with no other real comorbidities. So I'm seeing, problems with an uneven cadence, the gait speed is slower, there's a less weight shift to that left, kind of that narrow base. So let's think about where we might want to start. I've got a few ideas here. So watch the first one, and I started with thinking about how do I get a wider base of support, better weight shift, and a more even stride length. A simple external cue of those flat cones, dots, and the cue is just to walk to them. And looks pretty good, right? And with practice, it's even a little bit better. A little faster. Right? So that simple cue solved a little bit of my problem with my uneven cadence and uneven stride, but I still don't have really as good of a cadence as I want. So let's add a metric.
I thought it was going to be faster. I didn't do that.
So that was much harder for her. It was a novel task. It was new. She had not done anything like that before. And it took a lot of attentional focus and some practice to get her to be able to pay attention to that cue. So once we did it a few times, obviously with practice, she was able to get. So that evened out that cadence, but I'm still not where I really want to be, because to go to the next one here, I still don't have very good knee flexion. It's still a stiff left knee. And obviously we need to work on knee flexion and knee range of motion in our therapy sessions, but during gait, I'm going to practice some externally focused. And then let that knee drop towards the cabinet. Yeah. There you go. And then rock it back. Using the cabinet, and roll forward, roll right through that foot, let that knee drop. Good.
Just doing things to think about.
Mm-hmm. So rather than say bend your knee before you move it, I'm asking her just to put her knee up to the cabinet, get her knee to the cabinet. Okay, so just bend that knee, let it drop forward, kick it out, and then step on it and rock forward. Perfect. Rock back and slide it back. Adding a little more dynamic work with the swing, getting that leg to get out to that external cue. And then let's move into trying it with the external cues of the. You can see this is very challenging for her. Really with a little addition in this last video. It organically goes using a little bit of support, right? You could see her touch the fridge and the counter, because really to get that good quality gait, she should be using a cane, but she doesn't want to use a cane. So let's think about a stroke patient. So this is a left hemiplegic with pretty dense deficits here on the left. Let's watch her walk a little bit.
I gave him a large stringy piece. He kept not wanting the little.
Oh, that looks better.
I got him in there.
Okay, now you got to be quiet. All right, you feel like just to walk a few steps.
Can you sit out of the way?
Obviously, a step 2 gait pattern, some excessive hip flexion, not a lot of weight bearing or weight shift onto that left leg. Obviously, our gait pattern is fairly slow. So let's think about some pre-gait and gait activities using some different kinds of cueing. So here we have, and now just stop there, push your weight onto that foot. Now then shift weight back and step back to the other cone. Yes, and then let your hips go back. Perfect. So just practice that a few times. Step forward to that first, yeah. And then shift back to your left and step back with that foot to the other cone. So an external target to step 2. I am using some internal cueing. It is hard not to talk about shifting to your left, but my basic goal of just stepping from one goal to the other, from one cone to the other, is an external cue. So we worked on that in different settings. We did it with different targets, stepping over things, stepping to things, and then started to put it together with the addition of a laser light. Let's just start with your feet, both on the green line. See what that feels like, okay? Kind of just feel level there, right?
Okay, but Bird, you need to stay back. You just watch quietly.
All right, so when we walk, you're just going to push your walk right ahead and step to the line or past the line. Just right there, good, right there. Have your toe cross the line, perfect. Have your toe cross the line. Perfect. Perfect. Your toe cross the line. Perfect. So good. Now that's beautiful. And I might cue right here, Sydney, to get a little more bend in that knee. So she swings it forward and less side hip. There we go. Perfect.
I'm looking.
You do great. So that's a visual cue. She's just stepping over or to that line. I did at the end give her a little somatosensory cue. I gave her a little tap behind her knee to kind of facilitate or increase her awareness of letting that knee bend when she swung it through. So I added a little somatosensory cue. And here's with an addition of an auditory cue to work a little more on that timing, getting the cadence more even. Step, 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 slow step, step, slow, fast, step, 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 step. Look up and just imagine that line, okay? Once you're in 7 step. So better with practice, getting that right leg to move slower and the left one to move faster. And looking at another, someone with a stroke-like, but also has underlying multiple sclerosis. Obviously, what do you see? You're going to see a lot of hip flexion, excessive hip flexion, circumduction, a really flat foot contact. She's doing exactly what her therapist told her to do, which was to pick up her legs so that she could clear her foot. So let's try to work on that a little bit. A few quick clips again of using that counter as
shift
a
onto it. All your weight on your
cue
all your
to
weight
get
on
that
your left.
forward.
Right one bends. Keep that left hip at the
So
counter.
that idea again, push your hip towards the counter, and you can see she gets a much better weight shift onto that leg once we get that hip to the counter as that external cue. Let's see if I can get this one to go. It should have been
So
first.
try to drop the knee,
Struggle it is,
but keep the other one straight. There we go.
and with
That's
that
it. Good.
same
And then shift back
of trying to
and rock all the way back onto that back leg. Push with your arms a little bit. Yeah, sink back.
And then here we've got putting it together a little bit.
And put your weight on it.
One more time. To the count, a hip to the counter, and a weight shift on. So lots of pre-gait practice with external cueing. And here's our gait pattern after just a short little bit of work. Still issues, still flat foot contact, but a much better stride length. Here's a younger MS patient, recently diagnosed about a year ago. So let's see what you see when you watch him walk. That's with his boots on, and without his boots, it's a little more evident. He uses those boots to kind of help control some of his issues. So I see that right swing phase is slower, it's externally rotated, it's kind of getting a flat foot contact there. So I want to work on that. What am I going to do to work on that a bit? So let's add some external cueing. So on the treadmill, you're going to see a little bit of somatosensory feedback and assist with the TheraBand. We're just giving him that feedback of picking up that toe. And you can see that that's already looking better. So he's getting a better heel to toe contact. We're going to practice that there. We added a little bit of a laser to work on really getting that right leg to move a little faster. Actually adding them both the metronome and the laser, because he's younger, he can do more. I can add more cues for him versus when I added something with Marlene with the metronome, it threw her off with my other client, older client. Here's some auditory cueing, just focusing on kicking the ball.
Kick that ball.
So that was just kick the ball. And then as we put it all together.
Kick the ball. Kick the ball. Oh, you can hear that clunk, huh? Okay, make it really quiet. Don't let it make any noise. There you go.
Initially, the cue of kick the ball got that right swing much faster, less externally rotated, but he was still landing with the foot flat contact. So I added kind of that metaphor of landing, not to make a noise, to make it be quiet. So now on to some Parkinson's disease examples with Jen.
So just checking out our wonderful client Liz, seeing her just, I'm letting her just walk and just kind of taking a little bit in to see what are the things that we want to work on. You know, when Liz came in, she said she's really concerned about, her speed of walking. And so hopefully just by her also being aware of the things and the challenges that she's facing, thinking about the things that you all see there, that very narrow base of support, very small step length and very short steps, difficulty even kind of transitioning in that doorway, right? Definitely a little bit of asymmetry we can see between the right and the left leg. And very much, and just as she very much told us as she walked in, a slower gait velocity, even some challenges with turning. So let's look at what we decided to do for our treatment. I have to have a student, which is always really nice. So checking out Liz here, we can see her actually walking. We put down some visual targets. We did let her use support with our initial practice of trials. And as she got more comfortable, in fact, we were able to let her just see what she wanted to do. And the cues of those hula hoops, increasing her base of support, increasing that step length. So those were really easy cues to be able to do. And then as she got more comfortable, let's see how she starts looking even with that multimodal. So thinking about very using that metronome to help her get through those hula hoops. Also using another visual cue. This is actually a balance beam. So not having her be on it, but straddling it. Justin's giving her a cue to think about ice skating. Liz is from New York. And then look how this transitions into a great turn. That weight shift, that wide base of support just helps her transition into a wider base of support turn, increasing her safety. We have someone that has freezing of gait here, and these are just quick examples. I let Carol just kind of choose her walking speed, her cadence here. You can kind of see the step length is pretty short. We added an auditory cue, just a metronome. She's at the same exact speed, so that did not change. Yeah. So really nice way to be able to utilize that auditory cue to improve stride length, thereby decreasing those chances of freezing or even getting into a festination. Our last example, thinking about a little bit of atypical Parkinson's, someone who has lots of freezing of gait, and using those cues. Again, here's the somatosensory. Oh, there's my internal cue that I used, and it didn't get me anything until I said, pull forward. Pull forward. Yeah, reach the front of that treadmill. And that's my cue. That's what got me what I needed. It wasn't the heel. It was reach for the front of the treadmill. And then here's the last one. Again, we were looking at those cards so you can kind of see using those visual cues of the cards and how much better So again, being able to facilitate really good neuroplasticity and good learning practices is going to be really important.
A huge thank you to Maria and Jen for their expertise today. Thank you so much, ladies. We'll now be moving to the Q&A section of the webinar. All right, first question. So they follow the light ahead to walk with the headlamp?
That's exactly correct. Yes. So you can use, and again, if I am using a headlamp, I'm giving a big target. That headlamp is going to point. I'm going to give them a big target. Point towards the top of where the ceiling and the wall meet. So give them a target to point that headlamp. And instead of course, we'll see people, of course, looking down because they're trying to be safe in their 20-foot radius. So using that headlamp is going to help to get those eyes up to the horizon, but that headlamp is just a great visual cue for their eyes to take it up there to look at that light.
Anything in the environment you can use to point that headlamp to. If you're working on turning, you want them to visually scan their environment for safety so they can place that light on a picture, a target, something in the room.
Great, thank you. What is the metronome rate you use to start?
Oh, that's a fun
question. Our favorite answer, it depends.
And it does. I think a lot of times, it depends upon the task that I'm doing. But for someone like Liz that you guys saw, because I was trying to increase her stride length, I started out a little slower for her, starting it out at about 70 beats per minute. But with improvements and with her increase, I want to also increase her speed because that's one of her goals. So then I will start increasing that metronome speed as she becomes better.
And the slower pace is harder in a lot of ways, but it drives a lot of attentional focus. It works on other goals, depends really on your goal. And for Carol with that walking, trying to get up to normal gait speed, but when I slowed it down for my total knee patient, she had a hard time because of the balance requirements with going slow, and actually did better with a little faster velocity on the metronome.
Great. What is the name of the green rings that had ball bearings to provide tactile and auditory cueing?
Smoovey. That's a SMOOVEY. And they're made in, I think they're available now on Amazon.
Are these cues adaptable for visual and hearing impaired?
So it's very interesting. I worked with a patient yesterday who has double vision. So she was complaining that she has trouble if you ask her to look at something, then the double vision. So, using a headlamp or some kind of a target in that situation, it's really having a big goal, something to get that into the vicinity without having to focus on actually seeing that target. Hearing impaired, I think really looking at, there's a lot of research where if you use headphones, you can really get that out, get distractions and some of that background noise away, then I think you can get better results there. But, that's how I would adapt. I would make sure my cues are bigger, larger, brighter, more contrast for visual impairment, and then use some headphones.
It might also be important to then begin to use those somatosensory cues as well. That may be where you kind of get a lot of bang for your buck with those clients as well. Also, because especially with visually impaired, you want to help them utilize that somatosensory system as much as they can.
All right. So we'll now be turning over to the product portion of the webinar. We hope you can stick around just for a few minutes to learn more about the Next Stride. That was one of the products that was mentioned during the webinar, which is an advanced neurological cueing device that gets the user up and moving faster and moving for longer periods of time. Thanks for sticking around. Today, we're going to be talking about a product that's really innovative and unique that utilizes some of the cueing that you just learned about in the presentation. The product is called the next stride, and it allows for both auditory and visual cueing. And why this is important is that it really allows for the individual to set a goal for themselves, as well as keep pace and cadence with their stride. So the product itself, Next Stride, is going to attach to a multiple different types of mobility devices, such as a cane or a rollator or a walker, for instance. It's not going to come with the product, with the device, but the device itself, as you can see here, is shipped in a nice, concise little package and gets to you relatively quickly and is incredibly easy to install. It uses a band system. Once it's installed on the device, it allows for you to then engage that individual. Conditions that it's going to solve for kind of vary. You know, for the most part, we're really focused and looking at patients that have neurological disorders such as Parkinson's disease, where you could result in a side effect called frozen gait, which is basically cinder blocks, feeling like you have cinder blocks around your ankles and you're unable to take that next step. The Next Stride, with that cueing, both visual and audio, is going to allow for the individual to see and to hear and to move, which is ultimately the goal that we're trying to accomplish here. So other possible patients you might be looking at are CVA patients or perhaps post-op care patients, where you're really working on trying to set goals for them to take that next step. So let's now take a look at the product in action. The Next Stride that I have here attached to my cane took me all of 30 seconds to install, so quick and easy. I just turned the device on and I hit the button up here with the green line, which will present my visual cueing opportunity here. And then I have another button that I push to activate the metronome, which is going to create that pace for me. So as I'm looking down and I'm trying to get out of that fixed gait, I have a goal set for me visually, but then I also have the metronome helping me to get that step moving forward. And then to keep pace as I continue my gait. So this is going to be a great device that can be utilized for someone with a neurological disorder, but it also could be for someone that maybe is post-op care or a CVA patient. I can also turn the light. I can use it for create a medial line and give them an opportunity to pivot and move from side to side and weight shift, which is a really great tool because, again, that visual and audio cueing pairing is going to assist with that activity. I can change the length of the light. So if I want to create longer or shorter strides, I can do so. Maybe you have someone that shuffles and I want to incrementally stretch that stride, I can do so with the light as it presents itself and kind of tweak it as they go. So as you can see, quite easy, and that's the name of the game in rehab. Make it easy, but also make it a product that is functionally going to do something and the individual utilizing it is going to benefit greatly from it. The DeOro Devices Group has done a fantastic job of field work and clinical studies to support that their product does indeed reduce falls and allow for better ambulation, especially as it is related to neurological disorders. So they have a ton of evidence out there that we are certainly happy to share with you. I presented on their website as well. If you just look up Next Stride, you'll be able to see some of their videos in action as well. And as a follow-up to this particular demo, we're here as your support. So if you're looking for additional information, maybe you want tangibles, some of that marketing and or some of those clinical studies in hand, we can certainly help you out there. Or if you're looking for pricing, you can contact your account manager. So I really appreciate your time today and I'm looking forward to supporting you in the future. Have a great day.